Hello and good evening, everyone. I, Shahid Nazir Wani, on behalf of FCPI, a member of Clinical and Research Forum, welcomes you all for this insightful basic module session. It's my honor and gratitude to introduce the today's speaker, Mohammad Rashid sir, MPharm PhD. He is a postdoctoral research associate, Department of Pharmacotherapy, College of Pharmacy, University of Utah, USA. Dr. Mohammad Rashid is a postdoctoral research associate at University of Utah, USA, who is expertising in evidence synthesis, health economics, health technology assessments, and medical artificial intelligence applications. He completed his PhD from Manipal Academy of Higher Education as a DST Inspired Fellow with an award of Best PhD Scholar of the Year 2024. In September 2024, he completed his undergraduation B.Pharm and post-graduation M.Pharm from JSS College of Pharmacy, JSS Academy of Higher Education and Research, Mysuru, with a distinction during the period of 2012 to 2018. Later, he worked as an assistant professor and PharmD preceptor at Shri Adi Chungchangri University of College, Adi Chungchangri University. He got trained in health economics and outcome research from Maxman Healthcare Communication, Navi Mumbai during 2017 to 2018. Currently, he holds many professional responsibility in various national and international organizations, such as International Society for Pharmacoeconomics and Outcome Research, ISPOR, Federation of Clinical Pharmacists in India, FCPI, Southeast Asia Evidence for Policy and Partnership, for name a few. Dr. Rashid was awarded with two gold medals, including Frank May Gold Medal and Knowledge Gold Medal, for obtaining the highest mark in M.Pharm pharmacy practice at JSS University, and received Sri Ratan Tata Scholarship for 5 consecutive years for being in the rank list throughout his academics. He is awarded with Best Pharmacist of the Year 2023 from Adi Chunchangari University, Bangalore, Karnataka. Also, he is the recipient of many international and national travel registration grants for various societies such as ISPE, ISPOR, DST, etc., to attend international conferences and present the research works. Mr. Rashid has been recently awarded with the from Manipal Academy of Higher Education. He is an experienced systematic reviewer and meta-analyst with authored more than 70 scientific papers in various national and international reputed indexed journals, and also few are in pipeline. His research interest includes evidence synthesis, systematic reviews, meta-analysis, network meta-analysis, and pharmacoeconomic evaluation of medicinal products. He is involved in many works that are related to use and cost effectiveness of artificial intelligence, machine learning, and generative AI in various disciplines of health and medicines. He is serving as a peer reviewer of many international indexed journals. He also served as the coordinator in key personnel for many international conferences organized in southern part of India. He piloted many workshops, scientific sessions, and webinars on different aspects of clinical pharmacy across India with a mission to empower and motivate the young pharmacy graduates to adopt an ethical clinical research and practice and research. I welcome Dr. Rashid sir again for this insightful session. Over to you, sir.
Thank you so much, Shahid, for such a nice introduction. And uh, welcome everyone for this session. And today, as part of FCPI's Clinical Research Forum webinar, where a clinical research forum used to have the clinical research focused sessions, which will discuss on many clinical research designs, their conduct, how to look into the journals, publications, and all other aspects of research and publication. So today, in this continuing webinar series, we are talking on randomized and non-randomized interventional studies or controlled studies, where we will be giving an overview of what are the randomized controlled trials, and we will be touching on non-randomized controlled trials. And then we will be talking on what are the different terminologies and what are the different characteristics of randomized controlled trials, and what are the challenges and other things which encounter when we conduct a randomized controlled trial. So it will be an overall brief, and it will be an overall nutshell information, where we will be able to understand at the end of this session what is it all about. So moving forward, first I will be talking on some characteristics of randomized controlled trial. So always, not only randomized controlled trials, even non-randomized controlled trials, basically we call it as interventional studies. So if you look back to the study designs flow chart, there are two set of studies. One set of studies are observational in nature, and another set of studies are interventional in nature. So basically, observational studies means you are not going to do any kind of intervention, or you are not going to introduce a new drug therapy, or you are not going to change an ongoing therapy of a patient. You are just observing what is happening with that patient, and you are just noting down and conducting a research. Then that kind of studies are called as observational studies. Whereas another set of studies where you are going to introduce some new therapies, it might be a new drug in the market, or you are going to change some strategies of ongoing therapy, like you are changing a dose, or you are changing a duration, or you are kind of adding a new drug into the ongoing therapy, or any kind of intervention which has been identified as a new therapy, or it has been identified as an alteration in therapy. Then you are conducting a study on that to understand how this alteration is going to affect the patients. Then those kind of studies, I'll call it as interventional studies. So basically there are two type of studies. One is observational studies, another one is interventional studies. Then under this intervention studies category, we have multiple study designs. Like we have single arm studies, we have pre-post analysis studies, we have uh, the multi-arm studies, we have bi-arm studies or two-arm studies, and different set of studies. In this case, today's specific section, we are talking on two-arm studies, where you will have two arms in the sense one arm, two arm in the sense two set of patients. So always in the clinical trial terminologies, we say two arm. Two arm means two groups. So you have one group and you have another group. So out of these two groups, you will have one set of patients who are given with the treatment, and you have another set of patients who are not given with the treatment. So whoever is given with the treatment, then we call it as intervention arm, or we call it as treatment arm, or we call it as intervention group, or we call it as treatment group. Whoever is not given a treatment, we call it as non-interventional arm, or non-interventional group, or sometimes we call it as control group, or we call it as placebo group, depend on what kind of treatment you are giving to those set of patients. So now the question is, how come randomized and non-randomized is different? So basically, randomized and non-randomized trials follow all the procedures same, except the randomization process. Except the randomization process. So that's the reason I didn't give a separate kind of slides for non-randomized studies, but obviously I'll be discussing about the just intervention studies at the end of this presentation. So now the question is randomized and non-randomized trial. So basically, non-randomized trials also will have the same process of a randomized trial, except the stage called as randomization. So we will talk about what is a randomization, okay, in the coming slides. So now I will discuss some characteristics of this randomized and non-randomized trials. But from now onwards, I will be using only the term randomized controlled trials because only the difference is just not randomized. Remaining all are same in the process of a interventional study. Now, uh, please keep this in mind that whenever you think of a randomized controlled trial or non-randomized controlled trials, it will be always prospective. Now the question is, what is prospective? So prospective means you are conducting a study in a forward direction. Forward direction in the sense, suppose I'm starting my study today, that is October somewhere in 10 or October first week. My study will follow into the future. So all my procedure in the sense informed consent taking, randomization process, allocation process, treatment giving, following up the patients, analysis, everything will happen in a prospective way. Never happen in a retrospective way. No clinical trials sorry, not clinical trials, no randomized controlled trials or non-randomized controlled trials cannot be conducted in a retrospective way. So now the question is, what is retrospective? Because some people may not be understood what is retrospective. Retrospective means you are conducting the study right now, but you are collecting the data from a past information. That means we are just going back to the medical records of patients in 2020 or 2021 or 2022, and you are collecting their information, then that is called it as retrospective nature. So always remember, in randomized controlled trials and non-randomized controlled trials, always this will be happening in a prospective way. Now, the next point is that, so one thing you are clear that never RCTs will happen in a retrospective way. It always happen in a prospective way. Now the next one is comparative. Comparative is very important because randomized controlled trials and non-randomized controlled trials always should have a comparator. That's why I said that today we are talking only the studies which have two arms. Two arms in the sense, one arm I said it is intervention group, another arm is non-interventional group. So always this non-interventional group will be the comparator. So always the RCTs and non-RCTs should have a non-RCT. I mean that random. It's a randomized controlled trial, but not randomized control. So sorry, non-RCT. It's a controlled trial, but not randomized. So always think that this RCTs will have always a comparator arm. If you don't have a comparator arm, then you cannot justify it is an RCT. So always RCTs will have a comparator arm. Now the question is that what are those comparators? So those comparator can be anything based on the researcher. So sometimes it can be a placebo. Placebo means you are giving just a drug that is resembles the original treatment drug, but it will not have the active pharmaceutical content. So it can be a placebo or it can be any controlled treatment. Controlled treatment means you are giving all other treatment to the patient except this treatment. So sometimes we call it as usual care or we call it as controlled treatment, or it can be no treatment. One arm you are giving some treatment and another arm you are not giving any treatment. So it can be also a comparator. So basically there should be a comparator to compare the treatment effectiveness of your intervention drug. So that is the next characteristics of a randomized controlled trial. Next one is quantitative study. Quantitative study means the numbers and events will be involved in the randomized controlled trial. So randomized controlled trials cannot be qualitative, but nowadays, I'm not going to confuse you. So I'll say that randomized controlled trials will be always quantitative. Quantitative in the sense there will be some outcomes that can be measured in terms of number. So if I say one example, okay, you are going to conduct a trial on diabetic patients. You are giving some anti-diabetic medication, maybe some semaglutide, or you are giving some empagliflozin or any kind of newer drugs to the patients. So now the question is that what you are going to measure after this trial. So what obviously we measure some diabetic indicators. It can be HbA1c, or it can be a fasting blood sugar, or it can be some postprandial blood sugar, or it can be your even random blood sugar, RBS, or something like that. So whatever you are measuring, it should have a number. So always, HbA1c, we always go with 6.5 or below that. So you will have some measurement there. So what do you have? You have some numbers over there. The same case, if you are doing some trials on the hypertensive patients, you are giving some new drugs to the hypertensive patients, and you are assessing what is the outcome. So obviously they will have some outcome in terms of your blood pressure measurement. It can be your systolic blood pressure, or it can be your diastolic blood pressure, or it can be your heart rate, or anything like that. So basically, you should have some parameter to quantify the measure of effectiveness in this particular patient set. So that is why always the clinical trials will be the quantitative. But nowadays, sometimes what happens if the intervention is something focused on implementation research, then sometimes we collect the feedback from the patients, or we collect some qualitative data, but it will be always as a secondary outcome or additional outcome of the trial. It will not interfere with the primary outcome. So always in a RCT, or your interventional study is always your final outcome will be in terms of quantitative measures. That is basically the uh, your measures in terms of any clinical endpoint. So that is the another characteristics of a randomized controlled trial. Always the study will be in quantitative in nature. Next one is experimental. The first thing before I start my session, I mean this slide, I told you that there are two type of studies. One is observational, another one is interventional. So I already given you what is meant by interventional. So that is the same meaning here. It's an experimental study. So RCT is an experimental study where you are going to introduce a new treatment, or you are going to change an ongoing treatment therapy. So basically, it is an experimental study. It is not an observational study. The controlled condition in the sense, any RCT will have a specific set of criteria. It is not general criteria. If you see, I don't know how many of you might have seen a protocol for an RCT. If you see an RCT protocol, randomized controlled trial protocol, or if you can check clinicaltrial.gov, or if you go to CTRI, you can see some kind of RCT protocols. See, you can see some RCT protocol, and if you go through that, there will be thousands of pages, and out of that, if you look for the eligibility criteria, there will be a 2 or 3 page eligibility criteria where they will say the patient, suppose you are conducting a kind of diabetic study, anti-diabetic medication study, where you are going to include only the diabetic patients without any comorbidity or immunocompromised state, then the criteria will go like this. The patient should be adult. Then they define what is meant by adult. Adult is someone who is having more than 18 years of age. And then they may say that patient should have diabetes from this year. So they may say that patient should have diabetes from last 2 years. Then they say that what is meant by diabetes. Diabetes should be have an HbA1c level of 6.5 or 6.2 from this year to this year, or it should not it should have a fasting blood sugar level of this much. So they will bring some standard criteria like AD and diabetic international diabetic association, that criteria or something like that. Then they bring that into the definition. Then they say that what are the other criteria which they should have. They may say that the patient should not have any kidney diseases, or patient should not have any immunocompromised stage, or patient should have this, should not have this, should have this, should not have this. So like this, there will be a set of criteria. There will be a defined set of criteria. So basically, all the trial will happen with this particular criteria. So that is why it will happen in a controlled situation. So that is the reason always we say as a drawback of the any kind of trials that is in phase 2 or phase 3 trials, and that will be usually we say as a reason to conduct post-marketing surveillance studies, where we say that all the trials has been conducted in a controlled situation or controlled condition. So controlled situation means it have a set of criteria what the patient should be. It is not general. It is not just open for everyone. That is the reason always the trials will happen in a controlled condition. That I hope you guys understood. So then, if you do a post-marketing surveillance, that means phase 4 studies, then you can have it in a open for everyone. That time it will not become a controlled condition. So basically, the point is that the characteristics of RCT is always it will be controlled conditions. Controlled means limited patient settings or limited eligibility criteria. Then it will be always having a random allocation if it is an RCT. If it is a non-RCT, it will not have a random allocation of intervention and comparator. So I will tell you what is randomization. Then always RCT will be very rigorous. Always RCT will be very robust. That is the reason in the hierarchy of evidence mapping we always give RCT next to the meta-analysis. So systematic reviews and meta-analysis are the highest top level evidence. Then we saw that we can see that RCT as a next one. So RCT is always most robust and it's most rigorous. So it is very controlled, very minimal bias. That's why RCT is having higher values in clinical decision making. Now I'm going to talk you on some kind of aspects. So now I said you many times randomization, randomization, randomization. Now the question is that what is mean by randomization? So we can see here, uh, let me check if I have something to annotate. Yes, I do have. Okay, so I'm going to mark something which you can better understand what whenever I talk. So you can see that I said you what is mean by randomization, right? So randomization, don't get confused because many people, whenever I speak or whenever I discuss with the students or even some professionals, we get confused between the randomization and allocation. So first thing you understand, randomization is different, allocation is different, and I will discuss you what it means by the difference. So now we talk only about randomization. So the randomization is just a step in the randomized controlled study, but that is the most important step in the randomized controlled trial. If randomization is not happen, I am going to downgrade that study compared to a study which is having randomization. Suppose I have two trials, same topic, same population, everything is same, but one trial is a randomized controlled trial, another one is a non-randomized controlled trial. In that case, I am going to give the weightage to the randomized controlled trial because randomized controlled trials are having so much of value because they always equally distribute the participants into two sectors. There are multiple methods for that that we discuss, but basically randomization means it is a process of grouping the patients into two groups. That is randomization. Now you see, we are talking about the randomization. So randomization is a process. So suppose this is your total population, you are going to split the population into one is new drug, another one is placebo. So this process is called it as randomization. So this process is called it as randomization. So basically randomization is a process where you are going to do two groups. That's it. That is the process of randomization. Now the question is that how you do randomization. You can do multiple method of randomization. There are a lot of methods of randomization. So there are symbol randomization. Symbol randomization means you are just doing randomization in a simple way. If I say one example, okay, I have 10 patients. I want to make them into two groups. Okay, now what I can do, I can just take a coin and I can just toss and I can say that whoever come into tile, they will go to the intervention, and whoever come with the other side, they are going to be in the control group. So that is simple randomization. That method is called it as coin tossing method. Or I can do what I can do, I can just take some chits and I can decide whether they want to go to the intervention or they want to go to the placebo groups. So that is a simple randomization. There are computer generated randomization where we do some programming in Excel and other softwares where if you just tell all the conditions of your trial, the computer will give a chart where it will tell, okay, first patient is coming, go to intervention group. Second patient is coming, go to control group. Third patient is coming, go to intervention. Fourth patient, go to intervention. So like that, there will be a computer generated randomization. So there are multiple methods of randomization. Now the question is that why we do this randomization? This randomization we are doing to limit the bias. So one thing is that randomization is doing to make sure that it is having equal distribution, and another one is to make sure that there is no bias. So what is mean by bias? Bias in simple terms, bias means it is something that is the involvement of the investigator where the trial result can get altered. That means he can do some manipulation basically. So that is mean by bias. So that is why if you have the highest level of good randomization, we always consider computer generated block randomization as the best method compared to symbol or just block randomization. So at the level whenever you have less human involvement, because if you do just coin tossing, it is having more human involvement, but if you do just computer generated, there is no human involvement in the randomization process. So now, if that is computer generated, I have two trial. One trial, everything is same, but one trial they used computer generated randomization, and another trial they used coin tossing method. What I do, I will give the weightage to the computer generated randomization. Why? Because that is having less human involvement and it is having less bias. So that is the reason we give value to always to the randomization. So now the thing is, like I said, you multiple methods of simple randomization. You can have cost coin causing, you can use the date of birth, you can do multiple other methods as well. Now, next method is cluster randomization. Cluster randomization usually we use if you are giving some kind of intervention that is having public relevance. Maybe you are giving some educational interventions, or you are giving some kind of public health, specific intervention where we do the cluster randomization. So cluster randomization, what you do, you are going to cluster the patient. Suppose I am doing some interventions where I have the population from Mangalore, I have some population from Bangalore, I have some population from Kerala. So what I do, or I have some population from north side. So what I do usually, all the population coming from Mangalore side make as a single cluster. It will have 8 or 9 or 10 different institutions, and I will keep them as a single cluster. All the population, all the different institutions coming from Bangalore, I'll keep one sector. All the institution from north side, that is one institution. All the institution from the Kerala, that is another institution. So this way, I will cluster the population first. So one, two, three, four, four cluster. Then I will do the randomization. Okay, cluster one and two will be intervention arm, and cluster three and four will be control arm. So this is the way how we do the cluster randomization. So it is just basically you are clustering different population, then you are doing the randomization. Now the question is that why I do the cluster randomization? It is very important when you are giving some kind of educational intervention. Suppose you are having different universities which you need to give intervention. So what happened here? Suppose you take one place. Okay, you are taking Mangalore. So Mangalore will have different colleges, different institutions, and the different institutions will have different set of curriculum, different set of teaching methodologies, different set of infrastructure. So what happened in that case, there is a chance that if you choose only one institution, there is a chance that their infrastructure will influence. And if you choose another institution, so there are two institutions, one institution having a good infrastructure, another institution is having a low infrastructure. So what happens if you give intervention to those who are having good infrastructure? Obviously their score will be high, and low infrastructure will go down. So if you are giving only to the low infrastructure, the score will go high, and this institution will have the same. So what happened? There is some mismatch. To avoid this, we use kind of cluster. So all the Mangalore institutions into one cluster. So what happened? This cluster will have good institution. I mean, good institution in the sense good infrastructure institution, low infrastructure institution, middle infrastructure institution. So it will be a hub of everything, and like same all other institutions. So you are getting a mixed population which can represent the whole population, which can represent the whole society. It is not simply one institution. That is the reason we go for cluster randomization in this case of trials, in these situations of trials. So that I hope you guys understood. Next one is stratified randomization. So in case of stratified randomization, what we do, we are going to stratify the patient. Stratify means again we are going to subsect the patient. So subsect in that sense, we are going to have patients, okay, according to the age. We are having age from this age to suppose 30 to 50, 50 to 70, 70 above. So like that, first you are going to sect the population. That means you are going to stratify the population, or you are going to tell that the population from this economic background, low socioeconomic, middle socioeconomic, and high socioeconomic. So you are going to stratify the patient first, then you are going to do the randomization. So that is called it as stratified randomization. So then there is something called as block randomization. So block randomization means you are going to block the patient first. Block the patient means you can make different blocks like 2 block, 4 block, 6 block, 8 block, and it will keep going like that. Okay, so 4 block means you are grouping 4 patients into one block. You are grouping another 4 patients into one block. You are grouping another 4 patients to another group. So you have block of four. You have maybe 10 or 15 or 20 block of four, depends on your number of participants. Now, the same way how we do in the cluster randomization, here you are going to randomize the blocks. So it can be block of 4, block of 8, block of 10, or something like that. Block of 16, something like that. So basically, first you are going to block the patient, then you are going to randomize the patient. Now, why I'm doing this? The same reason. So suppose you are blocking 8 patients into one block. This patient will have low socioeconomic, this patient will have women, this patient will have men, this patient will have different age groups. So basically, in that block, there will be a different set of population. Different set of population means different characteristic population. So that is the reason we will get a good distribution of population. So that is the reason we go with the block randomization. So nowadays, in many of the trials, I used to see that they will do stratified block computer generated randomization. So that is the highest level. So you can do any methodology. So basically, this is the process. So randomization means you are going to group the patient into group 1 and group 2. So this process is called it as randomization. That's it. That only that process is called it as randomization. Now you did the randomization. Okay. I know I grouped. I just grouped. I didn't start any treatment, nothing. I just grouped. Okay, patient 1 into intervention, patient 2 into control group. That's it. So I just did the randomization. That is done. Now, what I need to do once the patient comes to you, you have to do many other procedure. I don't want to talk on that part. Once you do that, okay, once you do that, then suppose the first patient comes to you, you are going to take his randomization chart, and you're understanding that the patient needs to give intervention group. So you need to give the treatment. So suppose one day, suppose X date, your patient is coming to you. So patient reached into the hospital. So once patient is reached into the hospital, you need to give the treatment, right? And you are going to check the what is the randomization. And you understood that the patient is in the intervention group. So what you are going to do, you need to administer the drug to the patient. So you need to give the drug Y or drug, whatever the drug is. So you are going to give the drug, and administration of this drug is called it as allocation. Don't get confused. Grouping the patient is called it as randomization, and administering this drug is called it as allocation. So many times what happens, why it is two group? Why can't I just say okay randomization? No, you have randomization another step, you have allocation another step, because many times what happened, there are a lot of patients, they will be there in case of randomization, but they may miss, or they are not coming for allocation. That means they may withdraw from the study, or they don't want to continue in the study after the randomization, so there will be some dropouts or something. So that is the reason you have randomization as a separate process and you have allocation as the separate process. Now the question is that how you are going to allocate the drug. Allocation of drug can be in many methods. Okay, I'm giving you a scenario. Patient is coming to you and you took this randomization chart and you are the investigator. You took the randomization chart and now you need to administer the drug. So you know that okay, patient should be given uh, intervention drug. Now you don't know what is intervention drug. That is the beauty of RCT. You will have many packets or you will have a lot of envelopes. So usually we say allocation should be given into sequentially numbered opaque envelope, SNOE. So, or packets, SNOP also, sometimes we say. So it is sequentially numbered opaque envelope. That is very important in case of allocation. So there will be a sealed cover, cover 1, cover 2, cover 3. So there will be a lot of sealed cover. But as an investigator, you don't know which is intervention drug and which is controlled drug. That is the beauty of RCT. So you will be always blinded in RCT. You will be always blinded in RCT. That is what we are going to talk next slide. So you are always blinded in RCT. So here, okay, now the patient comes to you, you took the intervention chart, sorry, randomization chart, and you know that patient has to receive intervention. Now the question is that you don't know which is intervention. You are not going to know. So what happened? You don't know whether patient is receiving intervention or you don't know whether patient is going to receive the control group. So what you know, administer packet 1. There will be a packet for patient 1, just administer. That's it. Just administer. You don't know whether that is intervention, you don't know whether that is a control group. You as an investigator don't know, but if it is an open trial label, open label trial, like I said before, that time you will be knowing. So there are different type of blinding, different type of trials. So one is open label trial, another one is single blinded, double blinded, triple blinded. So open label means both patient and investigator, they know what is the treatment. So both of them know. So sometimes we have to go with open label. I don't want to discuss on that. So now, if it is an open label trial, both patient and investigator knows what is his drug, what drug he is receiving, whether it is an intervention or he is going to receive a placebo. If it is a single label, a single blinded trial, then only the investigator will know what he is going to receive. If it is a double blinded, both investigator will not know, even patient will not know what he is going to receive. Triple means both investigator, patient, nobody knows what they are going to receive, as well as statistician also will not know what drug he is going to receive. No, nobody knows what is that in that packet. No, they will have only packet 1. So patient 1 is coming. When patient 1 is coming, give packet 1. Patient 2 is coming, give packet 2. So there are different clinical research organization, clinical research associates, clinical trial management team, they will be doing all this work. So patient, investigator, nobody knows what is that drug. Just when patient 1 come, give packet 1. That's it, nothing else. So that is how this allocation will happen. And I already discussed you what is meant by blinding. Blinding means just removing the information or just masking the information, that is called as blinding. And I explained you what is mean by open label, what is meant by single blind, double blind, triple blind, and different characteristics. So these are the some other methodologies, sorry, other terminologies we use in the randomized controlled trial. So this is the process. So now patient came, you already did the randomization, you have the drug which is sequentially numbered opaque envelope, you just pull out patient number one came, okay, pull out packet one, just give it, that's it. Nobody knows what is that drug, that's it. So that is called as blinding or masking the information. Now next characteristics or terminology we use is single sender or multi-sender. That is simple, as you know. Single center means the whole trial will be happening in a single institution or single hospital or single setting. That's it. That is called as a single center. But if there are multiple centers, like one is in institution A and another one is in institution B, then it is multicentric. And this multicentric sometimes can be in different countries, then we call it as multinational. So sometimes it will be multicentric, sometimes it will be multicentric, multinational. So it depends. Next one is placebo controlled. Like I said when I was discussing you what is comparison. So if it is using a placebo, if the comparator is a placebo, then it is called as placebo controlled. But if comparator is not placebo, if it is some other treatment or if it's just casual usual treatment, there is no treatment, then they don't tell that it is a placebo controlled, they just say that randomized controlled trial. But if the comparator is placebo, then they say randomized controlled placebo trial, or they say randomized placebo controlled trial. So if it is a placebo, then we say that placebo control. If not, then we don't say that it is a placebo control. So these are some methodologies or terminologies which we use in the randomized controlled trial. So this is the overall nutshell or overall, you know, package of this information. Then that's how the trials will happen. Now I will show you how a trial will happen. Oh, I need to remove the markings here. 1 second. Yes. Okay, now we are going to talk about the process of a clinical trial. Now, I said you, okay, you have a protocol. It will take a lot of time. Okay, RCTs will take a lot of time, years, years. So that's why many times we say disadvantage of RCT is tedious process. Obviously, it is tedious process. So now the thing is like, okay, now you are an XYZ company and you need to conduct a clinical trial. So you call for participants, you got the participants, you need to enroll the participants. So the first process is enroll the participants. So to enroll the participants, you do multiple methods where you give advertisement, where you talk to the clinician, or they will give you the different patients and all. Now the thing is like, you remember I said you that there is a protocol. In that protocol, there will be a big list of eligibility criteria. So you need to assess whether that patient is eligible. Okay, patient one came. We will talk only about one patient. Okay, patient one came. You need to check the eligibility. So suppose if he is not eligible, in the sense, suppose your trial is focused on adult population, but the patient is pediatric. No, he will going to no. But if the patient is adult and it is matching all your criteria, yes. So if the yes comes, patient is eligible. Once patient is eligible, you need to set up many meetings again to check his eligibility, his enrollment, everything is finalized. Then you need to go for patient into the randomization. So now what happens? Like I said, if the patient is not meeting the inclusion criteria, gone. He's out. If the patient is not interested, I don't want to continue. Patient have the right to say at any moment during the trial, from the start till the end, he can just say, I don't want to continue. Not even you can ask why. There is no question of why. If patient is telling, I cannot, that's it. We cannot ask why? No. So they have the freedom, they have the will, they can remove be out of the study at any moment. Then is there maybe any other reason? Maybe patient is allergic to the medication, so we have to remove him. So like that, there will be multiple steps where you have to exclude the patients. So once randomization is done, then patient will go to treatment A and treatment B. See now, then only the allocation is coming. That is why I said randomization is different, allocation is different. Don't get confused. Now the randomization is done, allocation is done, patient is allocated to the intervention or patient is allocated to the control group. Patient can be either into this, either of this. Then patient has to receive the allocation as allocated treatment, and patient did not receive the allocated treatment. So sometimes there will be because of some reason they will not receive the treatment. So I don't want to talk numbers here. Just I'm showing you how the process will happen. So once the treatment is allocated, we are going to follow up the patients, both set. We are going to follow up the treatment B and we are going to follow up both patient treatment A. So we are going to follow up them. We will note down how many is not lost to follow up. There are many reasons. Maybe they moved from that settings to another setting, or they just not showing up. Many reasons. So lost to follow up, or they discontinued the intervention. They don't want to continue in that treatment, maybe because of some ADR or maybe because of some allergy, or they don't want to continue, many reasons. So we will follow up the patient. Finally, whoever is there after removing this set of patient, we are going to take for analysis. So always remember, whoever is randomized may not be there in the allocation. No, some will be removed. Whoever is allocated may not be completing the follow-up. No, some will be removing. Whoever is follow-up may not be completed the analysis. Some will be removed because of some reason. So there are chances patient can be dropped out at any stage of this trial. But basically, this is how an RCT will be conducted. So now this is how it will go. So whoever is there in the final analysis will be taking for them into the analysis part. Now, since it is number, since it is a treatment, we have multiple methods of analysis. So I just give you an umbrella, just give you a overview of what different types of analysis we usually do. Then we will wind up the session. So these there are multiple analysis you can do. Depends on the trial what you have. You can do, suppose sorry, suppose your trial is just continuous outcome, like you are checking HbA1c. It will be reported in average, or we call it as mean. Then you will be analyzing mean difference. You'll be just analyzing mean difference, that's it. So mean difference, then they will be doing some t-test, or you will be doing some, like advanced test, like regression or any other trial results. That's it. So I'm talking here only about the numbers, that means in the events. Uh, if you have uh, outcomes in in terms of number of events. So events in the sense, suppose your outcome is something uh, death. Okay, it is event. Death is an event. So your outcome is something death. Okay. So now my outcome is death. Now the question is that how many deaths happened? So what you have intervention group, you have control group, right? You have 50 in the intervention and you have 50 in the control. Okay. Now the question is that how many event happened? Suppose here intervention 10 death happened. In the control group 20 death happened. Now, what we need to do, we need to analyze, right? We need to find out how much is the risk of death. You can use a lot of different methodologies. Sometimes we use a relative risk. Relative risk is just a risk or incidence proportion of the outcomes in the treatment group and risk of the outcome in the control group. Now, how we calculate the risk? Risk will be calculated how many number of events happened in the intervention group to the total number of events happen, total number of participants in the intervention group. That will be risk in the intervention. So the same way that will be risk in the control group. So if you just divide how many risk in the intervention to the risk in the outcome group, sorry, control group, that will be your relative risk. So that's it. So if you find out, suppose, okay, so now what we can see here, the risk of death is lesser in the intervention and risk of death is more in the control group. So if you do this calculation, you may approximately get 0.5. So that is the risk. So if it is less than 1, if it is less than 1, then we say that there are less risk in the intervention. That means less risk of death in the intervention group compared to the control group. So always we go with 1 as a cutoff for relative risk. Okay. Now, how much is the risk reduction? So what I need to do, I need to reduce 1 minus 0.5. It will be 0.5. If you convert that into percentage, that will be 50 percentage. So we say that there is a 50 percentage lesser risk of death in intervention group compared to the control group. That's it. So that's how we interpret. Then absolute risk reduction, you need to reduce how much risk is happening in the control group minus how much risk is happening in the intervention. So you just calculate risk reduction in the control group and you just calculate that, how that is called as absolute risk reduction. This is relative, this is absolute. Always mind that. This is relative, this is absolute. Now why we need to have this? So if you need to calculate number needed to treat, sometimes we call it as number needed to treat, or sometimes we call it as number needed to harm. So for that, you need to have absolute risk reduction. So if you divide 1 minus absolute risk reduction, then you will get number needed to treat or you get number needed to harm. So basically you say that you need to have this many population to be treated to see how many harm will happen or one harm will happen. Okay, then there is something called it as hazard ratio. So hazard ratio will be always then when there is a censored data. Censored data means always a time is the component. Always time is the component. So if time is the component, then you need to calculate time person year, time person year. Then you need to calculate incidence rate. No, here we are calculating incidence proportion. Here we are going to calculate incidence rate. Once you get the incidence rate, you are going to calculate incidence rate in the intervention, and you are going to calculate incidence rate in the control group, and you are going to divide this. That will give you hazard ratio. So hazard ratio always we do whenever you have a time dependent factor. Time delta. So usually you can see hazard ratio using Kaplan-Meier curve. We do multiple methods. So usually we use Kaplan-Meier curve, KM curve. So to do the hazard ratio calculation. So once you do that hazard ratio, you will be able to tell how much hazard is there, how much risk is there. Then you will be reporting that. Even here also, it is cutoff is 1 for hazard ratio. Any ratio, cutoff is 1. Any difference, suppose your outcome is in terms of mean difference, then the cutoff will be 0. So it depends on your outcome what you are having. So always keep that in mind. Any risk ratio will be in 1, any difference will be in 0. That's having some statistical things behind that. I don't want to discuss all those things. So basically, these are some common methodologies where we report. Relative risk will be reported, relative risk will be reported, or we'll be reporting I don't know why, 1 second. So relative risk will be reported, or we will be reporting hazard ratio, or sometimes we will report odds ratio, but odds ratio will be reported in terms of mostly cross-control studies, or we call it, we go with sometime there is a risk estimate. Suppose your outcome is more focused on negative outcome, then we go for odds ratio, but I don't want to discuss odds ratio the under the RCT because it will confuse people. So that's how we report the outcomes. Finally, this is the just a total blue chart for all study designs. So I'll just show that so that you will get a sense of what exactly we are talking. Sorry. Okay, so I was discussing you in the initial stage you have observational study. So whatever you can see here till here is observational. and this is intervention. So, like I said, you can see always the randomized control trial is prospective. Suppose you are starting the study here, this is your present. Always your randomized trial will be prospective. Always your case control will be retrospective. Always your retrospective cohort will be retrospective. Your prospective cohort will be always prospective. So both observational studies and interventional studies are in prospective phase. If you are following up your patient but there is no intervention, just observation, then that is prospective cohort. So prospective cohort will be observation. But always the cross-sectional study will not be retrospective, will not be prospective. It is just cross-sectional study. That is why cross-sectional studies, cross-sectional surveys, something which is very important. So this is the overall picture for the study designs, and I stop at this moment. It exactly 56 minutes we are talking right now. So I'll just wind up my session, just telling this as Dr. APJ Abdul Kalam's quotes that excellence and achievement, success, everything is a continuous process. It won't happen as an accident. It never happen as a one-time process, or it just never happen. It need a lot of effort. It need a lot of hard work, and it is always continuous. And even after success or excellence or achievement, if you stop over, never stop, keep continuing. So it should be a continuous process so that it will keep moving. So thank you so much for attending this session. And I know that I had just 5 or 6 slides, but I spoke about 1 hour. And thank you for your patience. And I'll stop at this moment and will hand over to the moderator. Thank you.
Thank you so much, sir, for such an insightful session on randomized and non-randomized control trials. Even with the limited slides, you have explained all the fundamental concepts related to the clinical trials in a very efficient and better way. Can we take some couple of questions, sir?
Yeah, for sure.
For example, when it comes to the randomization or masking, so it is open label, we can say single, double, or triple blind. So whenever we have to initiate any clinical trial, uh, this blinding and masking is actually depending on what. When we should go with a double blind, a triple blind, we should go with the open label. Is there any specific guideline and criteria for that, for blinding mainly?
Yeah, there are different guidelines. Like we can go to the there is something called as glossaries, if I correctly remember. I don't remember exactly. If you go to the WHO website, or if you go to the even our ICMR clinical trial guidelines, or if you go to CTRI, or if you go to our ICH GCP guideline, or if you go to any standardized guideline, there is a set of rules for open label or single blind or double blind or triple blind. But which one to choose, that is going to the sponsor or CROs or to the investigating team or project management team. Okay, but there are set of rules when you can do, when you cannot do. So it depends on your infrastructure, depends on your possibilities. You can choose which one you want to do. There is no problem. But always remember, if you had a chance to do a double blind and you did a single blind, always you are downgrading the quality. So whenever there is a chance to do a higher level trial, investigators and team will always go for that. But there are some circumstances where you cannot do the blinding. Suppose I say one example. If your protocol, you are doing a surgery and your surgery is the intervention, and you are to give one group surgery and another group no surgery, because you cannot give an alternative treatment to surgery, right? You can't just simply stitch someone. No, it is not advised in clinical trial because ethical issues are there a lot. So if your intervention is something surgery, you cannot blind the participants, right? Because they are undergoing the surgery and your investigator will be doing the surgery, so you cannot blind the investigator. So in that case, the only option is go for open label, open label study. So there are some circumstances like that where you need to, go ahead with that kind of trials. So, and sometime maybe if it is a very new drug, so sometimes you cannot blind the investigator because you should know what my patient is receiving. So that time you can only blind the participants if it is very new drug in the market, something like that. So depends on the situation, depends on the ethical concern. Sometimes your ethics committee will not allow you to do blinded trials, or that case you have to go with that. So it all depends. There are a huge complicated process behind that. So, but there are set of guidelines how to do it, but what to do it is the decision of the project management team. Vani, you are muted. I'm sorry.
Sorry, sir. Can we take one more question, please?
Yep, please.
Sir, when it comes to meta-analysis, we are performing the meta-analysis by including the randomized control price studies. And for example, if we are choosing any area for meta-analysis, we are choosing any research question, for example, so we have to go with the data extraction and lot of things. But sometimes, for example, if we are planning for any meta-analysis and we are including only the randomized RCTs study, so which database we have to actually follow in order to understand whether the clinical trials are there, they are available or not. So, for example, when it comes to clinical trials gov.in, we are mostly using that for literature, which we are looking in paper publications. But for mainly for meta-analysis, so we need the clinical trials, and we just want to have that is a one kind of clear in when we check whether clinical trials are available on that specific area or not. So which area we should look into it, which databases are mainly preferred to that.
Okay. So if you talk about systematic review and meta-analysis, so the literature search have two part. One part is your published literature, another part is unpublished literature. So for always published literature, you have to have set of databases like PubMed, Embase, Scopus, or if you are only focused on trials, then you are mandated to search Cochrane Trial Registry, which is central. So for published literature, that is the databases. And according to the Cochrane thumb of rule, you have to search minimum 3 databases. So you can choose whichever you want to do. Okay, that is one set. Suppose your study is something nursing intervention. Okay. So if that is the case, you have to search something called as CINAL database. So CINAL is another database where there will be only nursing studies or such kind of interventional studies. So you need to search that. If your study is something psychological intervention, so you need to search some database called as PsycInfo. So there are some set of another set of databases where that is very focused. Suppose your study something on Chinese or traditional medicine. You need to search as a database called as CNKI China because that is focused only on Chinese studies. So if you are doing some RCTs or studies that is focused only in India, then you may have to look into CTRI databases. So like that, depend on the context, you have to go that way. And then next set is unpublished literature. So unpublished literature means they are not published as a full peer-reviewed article. There might be different sect, like you said, it can be a clinical trial document. So you can search any available resources according to me. So you can go with the clinicaltrial.gov, or you can go to the WHO clinical trial registry, or you can go to the if it is like I said, if it is specific to India, when I did one of my meta-analysis back in 2020, we were doing something on saroglitazar. So saroglitazar is a drug that is very specific to Indian population they were giving. So saroglitazar that was published in PLOS One, you can look into that paper as well. So in that case, we were looking only to the Indian databases like CTRI and all those databases. So there are specific what your research question, you need to look at it. So sometime if you are looking to some specific research question or RCT that is specific to suppose gastrointestinal diseases, so sometime we may have to look into the Gastrointestinal Society conference abstract as well. Not only to this, because some trials will be just published as a abstract or something like that. So basically, that is depends on what research question you have, what disease area you have. But basically, there are two set. One is published and another unpublished. But nobody will question you why you didn't look for unpublished literature. But according to Prisma, it is always good to have your unpublished literature looked after. According to the Prospero, always good to have look to the unpublished literature. And if you are not looking to the unpublished literature, it is not a complete systematic review. So again, which database? I given you a whole set of very wide varieties of databases. Again, choosing is depend on the researcher.
Yeah, thank you so much, sir. And thanks a lot for all the informations which you shared with us today. And I think we can wind up the session.
Yeah, it's yeah. Thank you so much and have a good day.
Yeah.
Bye.
Yeah. Thank you all for joining these sessions today. Thanks a lot. Have a nice